Good afternoon, everyone. Thank you. That was good. I am Alan Kriegstein, Executive Vice President and Chief Financial Officer here at Independence. And whenever I hear Menachem speak, which is like once a year, and we got to fix that, Harris, you have that assignment for the next 12 months. I'm always inspired by the things that he teaches us when he refers back to the Talmud. So the issue on the partnership, excuse me, we're definitely going to try to utilize at Independence Health Group. But like I said, I'm Executive Vice President, Chief Financial Officer at Independence. On behalf of the Independence Health Group, I want to welcome everybody, and on behalf of our Chief Executive Officer, Dan Hilferty, who is in Washington, D.C. today, and my colleagues, I'm very happy to welcome you to this month's Jewish Business Network Luncheon. When you took your seat today, and you'll see on your table, you probably noticed a small notebook and a pen. The books are from the Independence Center for Healthcare Innovation. What's the connection? Because we thought you never know when an inspiration may strike you, so here's a book to jot down your ideas on the go. Here's the best thing, though. It's low tech. It doesn't have to be recharged. So think about that. If you look at the book, it's kind of interesting. There's a kite on the cover, which is a reference to a famous innovator from an earlier time, someone who has obviously strong connections to the city of Philadelphia. Maybe someone has a guess who that is. Here's a hint before you yell it out. It's not Dr. Steve Udvarhelyi, our guest speaker today. Although, I do have the pleasure of working with him every day, and we have a lot of fun. Although, I have at times responded to him in my office when he asked me a question. What do I say to him? Go fly a kite. All right, so who is it? The connection. Thank you, okay. As Harris said, we last hosted the Jewish Business Network Luncheon in August. Since that time, I'm happy to report we've finished the first full year of implementation of the Affordable Care Act. It was great to see how many people in the country, more people were able to access health insurance because of the ACA, and we're pleased to be able to provide coverage for those eligible for ACA plans. The ACA, along with other pressures in healthcare, have spurred a plethora of innovation in the industry. If you recall, if you attended the luncheon last year, we had as our guest speaker Elliot Menchik from Dream It Ventures. He was here to talk about startup companies. But innovation has to happen in well-established companies too, such as Independence Health Group, if they want to thrive. And I would just say that innovation is in our everyday thinking and playing a role in the new developments in healthcare innovation and technology at this company every day. So it gives me great pleasure to introduce today's speaker, my colleague at Independence, Dr. Stephen Udvarhelyi. Steve is Executive Vice President of Health Services and Chief Strategy Officer. He also, that's a mouthful and keeps you busy every day, I know. But he also oversees the Office of Strategy and Planning, Innovation for the organization. He drives innovation and business development, as well as all the clinical and medical health services. Steve is an expert in healthcare from both the clinical and insurance aspects. For over 19 years, he has guided Independence through the many changes in the field of medicine and in the healthcare industry, always focusing on the health and wellness of our members, which is very important. Steve's a board-certified internist. He holds an undergraduate degree from Harvard University, a medical degree from Johns Hopkins University School of Medicine, and a Master of Science in Health Services Administration from Harvard School of Public Health, which probably means you were in school for like, what, 14 years or something? So you started here 10 years? I know. Anyway, it gives me great pleasure to introduce our speaker today, Dr. Steve Udvarhelyi. Let's give him a warm welcome.
I'll give you the 10 $10 later. Thank you. That was good. So, good afternoon, and thanks for coming here. So I am going to talk today not just about innovation. I'm going to sort of end my talk focusing on that, but I'm going to start really by trying to share with you some of the things that are driving change in healthcare. And one of the things that's nice about healthcare is that for those of you that are not in the business like Alan and I are, all of us at some point in our lives are patients or try to avoid being patients by staying well. So we all have a personal stake in it. And what I'm going to do is give you a little introduction about the company for those of you that don't know about this company. It's different than when I came here 19 years ago, and I like to sort of share a little bit about what we look like today. I want to talk about the value problem in healthcare, because I'm going to suggest to you that is really what's driving change, and I want to take it down to a personal level that each of us as individuals can understand, make the case for change, talk a little bit about opportunities, and then the role of innovation in driving those opportunities. So there's a little bit about Independence Health Group. It's not maybe a name that you've not heard before, but we're not just Independence Blue Cross in Five County, Philadelphia anymore. We are proud that we serve a little over 9.5 million members now in about 24 states and the District of Columbia. And we are a diversified company with national reach. You can see lines of business in the commercial markets, government markets, and subsidiaries. So it's been a nice growth story. We are part of the Blue Cross Blue Shield system, which serves, the power of that is that collectively we serve, even though we're 37 independent plans, 1 in 3 Americans. 86 of the Fortune 100 companies offer some type of blue coverage across the country. And for our part of it, last year we were just over $13 billion in revenue, tracking out, I guess this year to about $14 billion. And although the parent is a not-for-profit organization, and this is something that I don't think people say, we pay last year we paid $568 million in non-payroll taxes, because most of our business is going through for-profit companies. So we are a major contributor to the tax base in the region that we serve in. We talked about the Center for Healthcare Innovation. What you would hear from Dan, if he were here, is a vision that we all share in, that Philadelphia really has all the assets to be the Silicon Valley of healthcare innovation, the same way that Silicon Valley did in the digital sort of computer and tech space. We have the assets here, and I'll talk a little bit more about what we're trying to do to realize that vision in a minute. And we have a portfolio of about $50 million. Actually, we've just increased it in partnership with Comcast to about 100, where we're going to do targeted investments to drive innovation. In terms of, again, the company, we're about 9,000 employees in our various geographies. We've been in business over 80 years. And just to put some numbers to who we touch, 31,000 employer groups, and our network, both here, Northern Delaware, Jersey, et cetera, 163 hospitals and almost 50,000, pushing 50,000 physicians. So that's a little bit about the company that Alan and I have the pleasure to work in every day. So let me now switch to the value problem. This is a time of big change. It is probably the biggest change since the government got into the healthcare business with Medicare and Medicaid in the 60s. It's driven in part by the Affordable Care Act, but what I would tell you is there's a lot of trends that have been happening to push this business from a wholesale business to a retail business. Healthcare is becoming a retail business, and it's being driven by consumers. There is unbelievable consolidation going on right now. I used to say it was largely in the provider space, but if you read the papers in the last week, there's now the rumors of United and Aetna getting together perhaps. Somebody's going to buy Humana, maybe somebody's going to buy Cigna. So even the largest insurers this week are all in play for consolidation, and I think we're going to see that wave continue. And there's been an interesting shift in healthcare away from just focusing on individuals as a physician when you show up in my office to what's called population health, thinking about how do we take care of people regardless of whether they show up in the office or not, as a population of patients, and sharing risk between insurers and providers in what are called accountable care organizations. So a lot of trends. Here's the problem, first value problem. There are still, despite the ACA that, as Alan said, expanded coverage, there's still 30 million people that don't have any health care coverage. So we have not solved, I would say, the access problem to health care with the Affordable Care Act. Second problem is cost. Health care in the United States is not affordable. We are spending right now about 18%, pushing up by 2020 to 19 to 20% of the gross domestic product, which is why it's a great industry that drives. Philadelphia is meds and eds, so healthcare is a great economic driver in our region. That's good, but we have an affordability problem. Here's what's interesting about the public. In 1999, the American public said, what are you worried about most in healthcare? And not surprisingly, they said, I'm worried about AIDS, I'm worried about cancer, a little bit worried about healthcare costs, heart disease, which, by the way, heart disease #1 killer, disease killer in the United States. It was only 4th on the list, and smoking. Fast forward now, 2013, the #1 thing that people are worried about is healthcare costs. After that, access. Can I get access because of the affordability? Followed them by obesity, and then cancer, and this is surprising, government interference in healthcare. So even though the ACA was supposed to solve all these problems, the American public is now worried about government interference. Very different mindset. Let me get personal now on the healthcare cost side of it. This is a set of bar charts that show between '86 and 2013, where did we as the public spend our money? And what you'll see is it's the usual things: food, housing, apparel, transportation, gasoline, and then down there, healthcare and healthcare insurance, entertainment, etc. Well, what's been interesting in the almost 30 years between these two time frames is that most of these things have not gone up much. In some cases, they've gone down. Health insurance has gone up 170%. Healthcare has gone up 50% at the expense of what we're spending on food and other things. So the cost issue in healthcare is crowding out what we choose to have as discretionary income everywhere else. That's why the public is worried about healthcare costs. And as the cost of healthcare has gone up, this is just a chart from 2004 to 2014 in a 10-year period. If you're offering in your company healthcare coverage for your employees, in 2004 it cost you just under $10,000 for family coverage. To do that, you, on average, charge your employee about $2,500 for that. And as the cost gone up, basically what this says is you put a disproportionate share of that increase onto the employees because of the affordability issue. So while healthcare costs have gone up 69% overall, the cost to the workers has gone up 81%. Okay? So again, and it's not just a cost issue, it's a quality issue. Because healthcare, and healthcare is unaffordable. Here's the statistic not on the slide. The ACA basically says we're going to give you subsidies if your family income is below $100,000. It's actually $96,000 and change was where the subsidies start to come in. So if you have a family of 4 and your family, you earn $100,000, you don't qualify. Guess what you will need to pay if you go out and buy individual insurance, pay the premium, and then pay the co-pays, the deductibles, the drug costs at the pharmacy, etc. It will be, on average, 30% of your gross pay. It'll be $30,000 before taxes. That's not affordable for people that are just above the subsidy level. That's why a third of uninsured adults said they went without care that they knew they needed because they couldn't afford it. 67% of Americans worry that they're not, even with insurance, aren't going to be able to afford their health care costs. And 4 in 10 say that even with insurance, I have not gone to get care that I know that I need because of the cost problem. So that's a quality problem. The cost problem is not uniform in the United States. This is just a graph. I could have picked anything. This happens to be utilization of hospital days per capita. It shows the national average right there, sort of in the blue bar in the middle. We're the red bar, Philadelphia. We're on the left-hand side. This is also an economic development problem. Why is this an economic development problem? Suppose you were a large company, that building over there you can look at, a large company that could do business in any one of the 50 states, and you have to put a operation center somewhere, okay? What is the number one cost of running a business after you pay salaries? Health insurance, right? Health insurance is your number one cost of doing business after salaries. So what about Denver versus Philadelphia? You could cut your costs significantly by putting the same people in Denver because the health costs are lower. It's an economic development problem for our region and for our country. So this just shows you where the United States is. It is high compared to other developed countries, and I would say even not so developed countries. What's interesting about this chart is that what the government pays for healthcare in the United States is about the same as what governments in the rest of the world pay for. Where we differentiate our spending is what we do through private insurance. That's really been the big driver, not so much what the government pays. That's a cost problem. Let's talk about the quality problem now. This is a chart from a woman I know who used to work at Rand Corporation in California, and she did a study a number of years ago that said, when we know what we ought to do for patients, how we ought to take care of them, what are we doing? And what she basically found out is that more than half the time, 55%, when patients are seen by physicians or in hospitals, they do not get care that is clearly recommended for them. And it varies. It's as good as 68% of the time for heart disease and as low as, say, 25% in something called atrial fibrillation, which is an uneven rhythm of the heart. And to give you an idea, it's not rocket science. All it says, if you have atrial fibrillation, you're at high risk for getting a stroke, you should be on blood thinners. We're not doing it, okay? So for all the money we're spending, we're not getting clearly the quality we deserve. This is a heat map of the United States, and the reason I have sometimes less is more is there is not only are we not getting what we're paying for. This chart where the darker colors, this is quintiles. The darker colors are the higher cost regions of the United States. You can see where we are. We're in a darkly shaded area. And what they found is that when you overlaid the quality in those quintiles, the cost of care is about 50 to 75% higher in those high cost quintiles. But the quality is worse. The quality was actually worse for things such as preventive care, for how well heart attacks are being done, but people actually had a higher risk of dying from things like hip fracture, colon cancer, and heart attack in areas that spent more money on health care. So if you're the Medicare, this is all based on Medicare data. If you're actually the Medicare program, if you just took those high-cost areas down to the U.S. average, Medicare program could save 30% of its total annual expenditures, and arguably the people would be healthier. So we're not getting what we're paying for. And this is my last slide on sort of the value problem. It was taken from a guy I knew that used to work at GE a number of years ago, a guy named Chuck Buck. GE, you know, they're a world-class manufacturing company. They do things like make airplane engines. They're very focused, and I'm glad they are. Airplane engines, you want low defect rates when you're up there at 30,000 feet. So Six Sigma, which they are committed to, has to do with defects per million. So at Six Sigma, you have less than 3 defects per million things that you do. And this is a chart of defects there and where things are. So that RAND study that I talked to you about says overall healthcare in the U.S. RAND, that's where it is. It's up there at the top. I want you to go down to the blue. Airline baggage handling at Philadelphia Airport. Okay? And go down the bottom right. The only part of healthcare that's better than airline baggage handling at Philadelphia Airport, fortunately, is the anesthesiologists. They're close to U.S. best-in-class injury. So if you're GE and you're purchasing healthcare and you're committed to Six Sigma, this is a problem. This is a quality cost disconnect. So pause there. Hopefully that made a compelling case for you guys that we got something broken here that we need to fix, we need to change things. So let's talk about the case for change. Anybody recognize this guy? Albert Einstein. Why did I put a picture of Albert Einstein up here? What's his definition of insanity? Right, doing the same thing over and over again, expecting different results. That's what we're doing in healthcare. We're asking the doctors and the hospitals and the patients to do the same thing, and somehow we want results that are different from what I just showed you. So we have got to collectively figure out a way to change the healthcare system, and from our standpoint, it means collaborating differently as insurers with the doctors and the hospitals to enable better care, fundamentally different, move from what we have today, which is a reimbursement incentive that rewards doing more things, to doing the right things, value-based payment models, and more accountability for all of us in healthcare. Being much more transparent about cost and quality, right? Because all of us, when we go to get things, we really have a dearth of information today on what are we getting as consumers in healthcare, and then really engage us more fundamentally differently as patients, as individuals. Now, we believe that we are uniquely, as a company, positioned to help do this because we are connected. I know I should put a few of them up here, but we are connected to all of the stakeholders in healthcare. Why? Because we are the engine through which the financing of healthcare flows by and large. It's true in the commercial side, but we're also an intermediary for the government, right? We are also, whether it be Medicaid, managed Medicaid, which we do, or Medicare Advantage, the Federal Employees Program, we administer all of those things. And what that does is gives us access to a very broad range of information. In fact, a much broader view of information than any other stakeholder in the healthcare system has. And by administering that financing, we also are uniquely positioned to be the entity, that, as I say, that can give people a reason to care. I can't make you do something, but with financial incentives, both at the provider level and at the member level, the individual level, I can give you a reason to care about changing your behavior. So let's talk about some of the opportunities. So how do we take that position that we find ourselves in? Well, we think that we can take that data, that information, and we can enable both the doctors, and hospitals don't make decisions, although administrators in hospitals can help, but doctors in particular make them able to make better decisions and make the patient's members make better decisions by engaging them and enabling them. And let me give you some examples. So we've developed in our informatics organization a predictive model that is targeted to people with diseases like congestive heart failure, lung disease, and we said, based on what we know of them, can we predict who is going to end up decompensating and going to the hospital in the next 6 months? And we actually have a model that does that and gets it right about 70% of the time. So when I now give a list of 10 patients to a doctor and say, these 10 people out of the 2,000 that you have in your practice are at the highest risk for decompensating, they can go out and intervene. And we've done that. We've also reached out to the members through our health coaches and said, you need to pay particular attention to your health care. By doing that targeted intervention, we've been able to reduce hospitalizations in that high-risk group by about 50%. We want to go one step further. It's not just the people that have the disease. 25% of the US population right now is so obese they're at risk for developing diabetes in the near term. Huge public health problem. 25% of the US population is way too many to try to go out and target and get everybody to change. So we said, what if, using those same predictive models, we could predict out of that obese population who is most likely to get diabetes. So we partnered with NYU Langhorne Medical Center to actually develop that algorithm so that we can now go out and say to people, you are at the highest risk, you really need to make a behavior change, or in the next 6 to 12 months, you're going to be someplace you don't want to be, and motivate them to make change. Take that upstream. Again, using that reason to care, we've said to the hospital community, we will reward you now not just for the volume of what you do, but for the quality of what you do. And we've provided financial incentives for them to reduce cost of care and to reduce quality defects in their system, such as hospital-acquired infections, avoidable readmissions, and we've seen a tremendous uptake in the engagement of the hospital. So 90% of the hospitals in our network now are engaged in this payment model, and we've seen huge decreases in these quality defects in the healthcare system there, even by just putting $10 to $20 million per hospital at risk, even if it's out of $100 million worth of payments. So it doesn't need to be all the money, just needs to be enough to get their attention, and it works. On the physician side, we took a fundamentally different approach. We basically, some of you may have heard about this, but we created a new company. We said, we talked about the partnerships that was mentioned at the beginning. We said we don't have all the expertise needed to fundamentally change the way care is provided at the primary care level. So we partnered with DaVita Healthcare Partners, a company that's been in the population health business in California, Nevada, Florida, elsewhere for years. And we said, we're going to come together and create a new company here in Philadelphia. We've signed up a little over 350 primary care physicians. And what Tandem Health is going to do is give those physicians an infrastructure that allows them to have a 360-degree view of their patients all the time, and then build out a delivery system capacity, because this is what's missing between the doctor's office and the emergency room of the hospital. How do you provide people a support service there to sort of get care when they need it, so that, or to reach out to them if they fail to show up for an appointment, so you're keeping them healthy. And this is going back to, I say, a population-based approach to care. That's what Tandem is going to do. Let's shift now to sort of the consumer change in healthcare. In 2010, the individual healthcare marketplace, people who individually buy health insurance, was about 35 million. You can see it's divided up here into sort of different types of programs: Medicare, Medicaid, individual, small group, et cetera. This year it's going up to about 52 million. By 2020, next 5 years, it's going to be well over 100 million. Those individuals are going to bring into their individual purchasing decisions a little over $500 billion of purchasing power. That is going to be transformative to the way that decisions are made, because this is the shift from the wholesale to the retail model of healthcare. And that consumerism has a lot of different dimensions. And I would say that when we think about it, most people think about the consumerism issues mostly what I would say the left hand of the balloon here. Oh, well, we're going to give you information on choice, on price, on quality, on value. What I suggest we also need to think about is the right-hand side of the balloon. Because in most retail businesses, people make choices on service, ease of use, convenience, etc. So think about your own purchasing decisions and how you're bringing those experiences into healthcare. And then think about, for those of you that are my generation, my kids, okay? I mean, my kids are used to doing everything on this, okay? So they do their banking at midnight on Sunday on this. This is where healthcare is going to be for them. All right, they're not interested in sort of the way we did it, and getting in a car and driving downtown and finding a place to park and going there. So I would suggest to you the reason this is important is the healthcare industry, and I don't just mean insurance, but in particular the delivery system, is not designed as a retail experience. How many of you have been to a doctor's office or a hospital outpatient department in the last year? Okay. How many of you have been to an Apple store? Same thing, right? No. Okay. I rest my case. Apple's a retail experience. Doctors and hospitals, not so much. $500 billion of purchasing power is going to change that. Okay? We do need to give people information about the left-hand side, cost and quality. This is an example of what we do on our website. We will actually give you information about the cost of procedures you're thinking about getting and the quality as best we can have it. But what's not shown on this page, what's here, is also patient reviews. You can go on our website and you can rate your doctor, and we'll aggregate that information and we'll show you why is that important in a retail environment. Again, just let's personalize this. How many people have bought something online, Amazon, etc., in the last year? All right, great. Me too. I try to slow down my family a little bit, doesn't work. How many people that bought online read a review? How many people will admit that something in that review, as you're going through, changed your purchasing experience? Okay, here's the fascinating question. Who wrote the review? You don't know. What's their qualification? You don't know. Are they an expert? It could have even been something technical that you bought. Maybe it was a computer, maybe it was something else. It influences your decision. That's where we're coming in healthcare. So I want to go back to that right-hand side of that balloon. Patient experiences in healthcare, the convenience, the experience, etc., is going to drive our individual decision making as we go seek services, as we go seek to buy insurance, etc., because it's going to come down. And a lot of it will be based on price and convenience. Think about you buying airline tickets. My next door neighbor, who's a retired United Airline pilot, tells me these are the planes you ought to get on, these are the planes you shouldn't get on, here's the quality of the airline crew, the pilot training at this airline, etc. Do I look at that? No, I go on and it's what time does it leave, what time does it get in, and how much does it cost? Right? I can make the same analogy in healthcare. So that's where we're going to go. So let's shift now for a little scary, right, when you think about that. But the public is not. We're not stupid as individual consumers. We're actually pretty smart. That purchasing power decision has never really had an ability to impact healthcare, but those changes will open that up. So let's talk now about the role for innovation. So for us here, what we talk about is innovation really from a human-centered perspective. We want to put the individual, the patient, the member at the center of that innovation to change healthcare in a positive way from their perspective. And these are really the parts of our strategy. And hopefully this strategy will make sense given some of the changes that I just mentioned. One, change the end-to-end healthcare experience. Make it a better experience. Two, innovations to help individuals manage their own health. Put them in charge. Transform the care delivery, right? By that we mean we've got to have the actual delivery of care be different than it's been if we're going to bend that cost quality problem. We can't deliver care in the same fashion. And then lastly, for us, it's really diversify the kinds of value added that we can bring to the equation through our products and capabilities. So going back to some of the things mentioned, what have we done? So we recently announced through the Chamber of Commerce, the CEO Council of Growth, an initiative. We were one of 8 founding members in a regional healthcare innovation collaborative where we want to make Philadelphia the global leader in healthcare innovation. This is bringing to reality that vision of this being the Silicon Valley of healthcare innovation. And you can see it's an interesting mix of companies that were the founders. So us, some provider organizations, Jefferson Penn, Safeguard Scientifics, an investment company, Comcast, and Ben Franklin Technology Partners. And the idea here is really to make it easy for companies that want to get into healthcare and do something innovative to connect to the assets that are collectively available in Philadelphia and to grow their businesses here. And it really builds on an earlier idea that we had. It was a partnership we did with Penn Medicine. And you heard the speaker, Elliot, last year from Dream Adventures, where we basically said, let's start a healthcare incubator, where we said Penn and Independence would jointly fund 10 companies a year to come here, to start, to bring their ideas here, and hopefully to grow their businesses in the Philadelphia area. These are small businesses. These are just examples of some of the companies that got started. Most of these are still in business, and most of these are still in business here in Philadelphia. So it's an idea that worked on a small scale. We think that regional collaborative can scale this up to a much bigger level. We've done some targeted investments in individual companies, and these are just 3. Array Health, which does, it's an infrastructure platform for administering private exchanges. Lumiata, which is an analytics company. I'll give you an example of that. And then CareCam, which is a locally based company here that is using, basically smartphone-enabled interactions with people. But Lumiata is an interesting company. They're actually based in Silicon Valley, and they have a Google-type analytics engine. So Google's really smart, right? When you search 6 things, Google says, based on that 6-thing pattern, I know what the 7th one is, and I know what the 8th one is. And I'm just going to put them right up there for you. So Lumiata took that to healthcare. They mapped out all the adjacencies in healthcare. So what they basically said, if you've got diabetes and hypertension, there's a pretty good chance you're going to have kidney problems at some point down the road. So it mapped out for us a way to intervene with members, going back to this, before they even know they have the condition. And what we actually did is reach out to those members, had them come into their physician's office, and sometimes made a brand new diagnosis of a disease that was there based on probabilities, but they didn't know they have, and intervene early in the food chain. So I'm going to wrap up with 2 different things. Think differently. For us, when we got into the Affordable Care Act, we had to think differently about how to engage the individual consumers. This is a picture of Ivy Express, which is a mobile truck. It is literally a mobile sales office. And so we said, rather than waiting for people either to come to our lobby, which they did, taxi drivers actually would pull up in front and get out and come in and sign up for health insurance, get back in their cab and go off. We were very big in the taxi cab market. We sent this out in the community and made a full-scale commitment to meet people where they are and to do that differently. We have another one of these that's actually a mobile health van, which we can take out and do health screenings and intervene and do the same kind of things to meet people where they are. So for us, that's sort of an idea of sort of using innovation to sort of think differently about how you interact with people. This is I'm going to end on. And the reason I say, are you ready, is I want you to think about now what I would call disruptive innovation in healthcare. And it sounds like a good thing, but reason I say it's are you ready, I want to paint this picture for you. Disruptive innovation, an example of disruptive innovation in the computer industry was the laptop. So the laptop, when it first came out, was technically an inferior computer to mainframe computers that businesses used, or even the desktop computers, right? Doesn't have as much computing power, the disk drive storage is less, etc. So traditional IT people said, yeah, it'd be crazy. Nobody cares about this. This is a hobby device. It's never going to be mainstream in the business community, right? Well, all the manufacturers of those large disk drives for mainframe computers, those companies now are either non-existent or they've shrunk, and you can see where we are with laptop computers, right? So it's a disruptive technology that comes in maybe inferior in some ways, but it's good enough and it meets the need of the public. So what does that look like in healthcare? Anybody here know what organization has said they are going to be the largest provider of primary care services in the United States? Walmart. Not a hospital, not a doctor's office, Walmart. Go back to that chart. Meet them where they are. That van, meet them where they are. Why? Because Walmart has a national network of places where people are already going. So they started out, remember, as one kind of company, and then the retail pharmacies said, don't worry about them. They're never going to do anything, right? Then they did $4 generics. Well, all of a sudden, the retail pharmacies aren't so happy. They weren't in the food industry, right? And grocery stores, don't worry about them. They're never going to. Now they're there. So people are now going there not only for the big box stuff, but they're going there for their grocery shopping and for their pharmacy shopping. So they're just going to carve out a corner of the store, all right? And Walmart's core competency, supply chain management. That's how they get low cost, and they manage the supply chain. So what is Penn and Jefferson going to do when Walmart says, we just have a national, we've set up nationally a nurse practitioner-based practice in every single one of our places, backed up with a high-definition video and a national contract to the Mayo Clinic, Cleveland Clinic, and Johns Hopkins. Oh, and by the way, we've got a transportation authority that can get you there, online scheduling for your appointments, and it's now in every Walmart. If you're a traditional health insurer, how do you compete with that? If you're a traditional health provider, how do you compete with that? There is a reason why Minute Clinic and CVS in Philadelphia has seen a year-over-year 15% growth in visits, while the hospital outpatient departments are seeing a 10% per year decrease in outpatient visits. So disruptive innovation is going to be non-traditional entrants. So it's going to be Walmart, it's going to be Amazon. And when my kids, just like banking, when you can go on here and visit your doctor at 12 o'clock at night on your iPhone and then click and get a scheduled appointment if you need it for next day, that is a disruptive way to provide health care. And I think that's coming in our lifetime and will fundamentally, I think, change the way healthcare is provided, but also how we as an insurer have to finance it and deal with it. So I will leave you with that, and if there's a few minutes for questions, we can do that too. So thank you.